morning, everyone. I'm Fred Iscari, and I just wanted to kick things off by welcoming everyone. It's nice to see so many old friends here in the audience and some new ones, too. And we're excited to have this meeting, really driven by the Wilson Disease Association, to bring together Wilson patients and caregivers and providers to discuss issues important to the Wilson community. So welcome, everyone, and thanks for coming. I know it's a busy time. So the program, is in your book that was at registration for the full schedule with topics and events going on, and hopefully there'll be something that interests everyone. If not the entire program, at least parts of it will interest everyone, I'm sure. The restrooms are immediate left out of the ballroom, located near the lobby in case anyone's looking. There's a Wi-Fi access password, Hilton Honors Doubletree meeting, and then Hilton 2025 is the password if anyone needs to log on, but hopefully you won't be on your phone throughout the entire meeting, so maybe you don't need that. But anyway, when you hear the bell, it's time to return to your seats, so that's when we have breaks and things. We want to keep the meeting moving on schedule. So please, when you hear the bell, that's what it means, is we're getting ready to start and return to your seats. Roundtables are going to be held in salons A and B during lunch, so people can mingle, and you'll get to meet with speakers and get to know the WDA board and staff who are here. There's also some specialty pharma roundtables in salons A and B from 3 to 4, and so you'll have opportunity to ask questions about the medications, learn how the specialty pharmas ship the medicine and access it, and support the patients, and also you'll be able to give them feedback, which is something one of the main reasons they're excited to meet you all, is hear how they can do better and what they're doing right, and so forth, and then engage in small group discussions. So in terms of question and answers, we're going to hold questions till after the talks, and then use notepads to enter in the questions. So write down questions on your notepads, and then we'll pass them up, and be sure to include who you're directing the question to if necessary. And so volunteers are going to collect the questions at the end of each session, and then they'll be read aloud by the moderators, so everyone knows your question and can hear it with the microphone, and if we have duplicate questions, we can try and merge them together to keep the discussion going. So with that, we'll start off today's events with our Wilson's disease trivia expert, who's Alice Williams. I'm told this was the highlight of a meeting in Toronto, was the trivia session that Alice led, and she's here from Toronto to lead the trivia session today. So thanks for coming, and she's also a Wilson's Disease Association board member, so which we have several in the room. And hopefully you all will get a chance to introduce yourselves, as well as some former board members, so everyone can mingle.
Good morning, everyone. I feel like the teacher. I said good morning, everyone. Okay, so fun with Wilson disease. Who knew? I'm sure everybody here has played Kahoot. Do you want to get on your phones and call up Kahoot on your browser, kahoot.com, KAHOOT.com. You can put in that PIN number and create a profile. Is everybody kind of getting online? Or you can just follow. Okay, we have Lindsay and Ginta. Put in your real name, fake name, your favorite sports member, team name, whatever you want to do. So we have 23 questions. This is just really fun and just a warm-up. And, yeah, to see how much you guys know about this disease. And hopefully by the end of the day, you'll know a lot more. We do have 3 wonderful prizes for the top 3 winners. So we'll just take a few more minutes, and then we'll get started. Pardon? Okay, let me know. Let's just take a few minutes. This will go super quick. There are 23 questions. I think most of the answers are correct. I'm sure if they're not, someone will tell me. Okay, we've got a few more. This is good. Raise your hand if you are still accessing or can. Oh, alrighty. How many patients are in the room? Raise your hand. How many caregivers are in the room? I'm a caregiver too. And how many pharma partners? Yes, we love our pharma. Okay, why don't we get started? If people are going to join, that's fine. So, question number 1. Oh. Wilson disease trivia. 3, 2, 1. All right. Question 1. What is the medical name for Wilson disease? Wilson disease is kind of the generic name. Is it hepatitis C, hepatic fibrosis, hepatolenticular degeneration? This is why I did not go to med school. Or hepatic degeneration. So you've got 5 seconds. Is it red, blue, green, or yellow? So just click what you think the right answer is. We have a few votes coming in. We will, you'll be able to keep track as you go how you're doing compared to the others. All right. JW, it is hepaticular degeneration. I'm really happy it's called Wilson disease because that is a mouthful. Thanks to everybody. So next question. What is the full name of the doctor who first described Wilson disease? Is it Samuel Alexander Kinnear Wilson? Is it Wilson Frederick Joseph Wilson? Is it Archibald Lloyd George Wilson? Or is it Michael William Jonathan Wilson? There is a picture of the gentleman. All right. Obviously, all the last names are Wilson, but what was his first 3 names? It is Samuel Alexander Kinnear Wilson. American born, but moved to the UK as a young man, older man, and first wrote about this very mysterious condition and disease. Okay, next question. JW is still strong, whoever JW is. In what year did he publish his landmark thesis, which Rhonda has seen in person? Was it 1921, was it 1911, or was it 1931? When did he first write about this crazy, mysterious disease? Oh, we have a lot of time to mull this one over. 21, 31, or 1911? It was 1911. He wrote his thesis. He didn't name it Wilson disease. That didn't come for years later, but he was the first one to kind of paint this connection between the liver and the brain and psychoses as he was seeing with some of his patients. So we owe him a debt of gratitude. One of the first researchers of many to explore this disease. Okay, who's in the leaderboard? JW. Okay, you guys got to chase this guy. Next. What is the defective gene that causes Wilson disease? Is it BX123, ABC123? Okay, we know it's not that one. ATP7B, or is it XTN481? So the defective gene that means your body can't process copper. If somebody says ABC123, you are clearly somebody who dialed it in at school. All right, I think we're good. Joel, you got to step up. JW's beating. ATP7B. What year was the gene discovered? So Dr. Wilson wrote about it in 1911, but it wasn't until decades later that they figured out what this defective gene is. Was it 1993? Was it 1978? Was it 2001? Or was it 1981? And this was part of this whole DNA mapping. There was a big movement afoot where they kind of looked at all the DNA in the human body and discovered so many mutations. It was 1993. And I believe that project was many years, like early 90s. So 1993 is when they actually knew the gene that caused the problem. Okay, next question. I'm not going to give any more accolades to JW because he's going to get a really big head. Approximately how many mutations are there? So not only that one gene, but there's so many different mutations. Is it 700 or more? Is it 500? Is it 241? Or is it 1,000? And I'm sure for many Wilson disease patients, you probably know the particular mutation that you have. Yep, it's 700 plus. And I think they're still even discovering more. So that's why it's a very difficult disease and can manifest in so many different ways. Alrighty. We're moving through. How common is it? I don't know if that's phrased correctly, but is it 1 in 3,000 people? Is it 1 in 30,000? Is it 1 in 300? Or is it 1 in 10,000? So if you take a population of, let's say, 3,000, is it just one person and has it? We'll see. It is 1 in 30,000. Hence a rare disease, because everybody knows a rare disease means it's only 1 in less than 2,000 people. And there are 7,000 plus rare diseases. That's a bonus knowledge for you. How many Americans are affected? So I know this, some may dispute this, but this was me. I'm like, okay, you guys are, I think, 400 million people, roughly. If it's 1 in 30,000, is it 11,000? Is it 1,500, 3,000, 15,000? How many Americans have Wilson disease? By my math, I'm going to say it's 11,000. But I understand that we believe half are not even diagnosed, which is why we're here doing the work we do, so we can help everybody. But yeah, all right, JW, there you are. No, kudos to you. Okay, how many people worldwide are affected? So I think there's 8 billion people on our planet. 545,000, 265 to 275, 2,730,000, or 1 million people. How many people worldwide are affected? 1 in 30,000, 8 billion, 265 to 275. So still a relatively small population when you think about it globally. Okay. At what age range? And this is probably contentious too, because as we know, you can be diagnosed at any age. But is it generally age 5 to 35? Is it 16 to 36? Is it 21 to 51? Or is it 30 to 50? At what age range typically? This is not written in stone. 5 to 35. So my 2 kids have Wilson disease, and I can tell you they fit that 5 to 35. My daughter was 19, my son was 22. But as we know, people are earlier, obviously later, because of all the mutations, but generally I think that's kind of what's considered the standard. Go KU. Ooh, bravo. JDMW, I'm sorry. Okay, we're halfway through, guys. How common are carriers? I'm a carrier, obviously. Is it 1 in 9,000 people, 1 in 90, 1 in 900, or 1 in 700? How many carriers are there that may or may not pass the defective gene to their offspring? It is 1 in 90. Oh, okay, I see. Yeah, 1 in 90. So it's pretty common. I mean, for many carriers, I had no idea I was a carrier. Oh, JW has jumped back. Okay, go KU. What's the chance that 2 carriers, when they have a child, that they would pass the genetic mutation to their baby? So again, the 2 carriers, is it a 75% chance? Is it a 25% chance? Is it 50? Or is it a 65% chance that they would pass the genetic mutation to their baby? It's 25% chance. So, you know, carriers have good gene, bad gene. You can either just give both good genes or one of each. And so, yeah, it's only a 25% chance. Go KU knows his stuff. Who identified penicillamine and later advanced trientine as a treatment for Wilson disease? Was it Bill Walsh? Was it Franklin Watson Smith? Was it John Michael Walsh? Was it Franklin Samuel Woodsworth? So I put the picture of the man. He is British, I'll tell you that. It's John Michael Walsh, and I think many people maybe know him. We owe him, like Dr. Wilson, a debt of gratitude. He's the first one who discovered penicillamine as a possible treatment. It was the first time that there actually was treatment that could remove the excess copper from your system. So, what year was it first introduced as a treatment for Wilson disease? Was it 1956? Was it 1973? Was it 1981 or was it 1964? My birth year. Which is also when Tim Hortons started. I think you guys actually do have Tim Hortons in Michigan. Sorry, I just got to plug Canada a bit. It was 1956 that he first prescribed penicillamine to a patient in England, and she was in terrible state and recovered and married and had kids and lived a long, great life. So owe him a debt of gratitude. Next, please. Moving on, Trientine, which I'm sure many take here. What year was that approved as an orphan drug by the Food and Drug Administration? Was it 1985, 1981, 2002, or 1991? So the first time that the U.S. government said, sure, let's try Trientine. I hope I got this right, because now I'm confused. 85, does that sound right? Okay, 85. Anne, we'll ask later. I love it. See, women do that, right? Slow and steady, and then I love it. Okay, in what year was zinc acetate approved as maintenance treatment? So penicillamine, Trientine, zinc, sort of maintenance. 1997, 2007, 2017, or 2001? Zinc. It was approved in 1997, so not too long ago. And as we know, there's many types of zinc. There's medical grade, off the counter, but also a very effective treatment. Okay, Anne, come on. In what year was Wilson Disease Association founded? Was it 2003, 1983, 1991, or 1998? And hopefully you follow us on Facebook, LinkedIn, Instagram, YouTube, Twitter, or X, and check out our website. 1983, so over 40 years. Incredible story. Carol Terry, the co-founder, very small, at a kitchen table, upstate New York, just to help one family with treatment expense, and look where we are now. So it's pretty incredible. When is International Wilson Disease Awareness Day? I don't even know if you know we have that, but we do, and this coming year will be the third year. We're trying to build an awareness day. Is it December 6th, December 21st, February 28th, or is it January 1st? So, and that's a sort of a W that I'm doing for Warrior. December 6th, which is the birthday of Dr. Wilson. That's why we chose that day. It's his birthday. Okay, we're in the home stretch. So building off the success of Wilson Disease Association, US-based with Canada chapter, we actually have created an international group. What is the name of the international group? Is it the International Federation of Wilson Disease Patient Groups, Worldwide Association of WD Groups? Is it Wilson Disease Global Alliance, or is it Wilson Disease International Patient Groups? And I can tell you there's, I believe, about 25. It's the Wilson Disease Global Alliance, relatively new group. There's about 25 patient organizations around the world, and we're trying to work together to raise awareness globally and, share resources and ideas. One of the biggest projects is Wilson Disease Awareness Day. Okay, Centers of Excellence. I think we're familiar with one close to here. How many Wilson Disease Centers of Excellence are there worldwide? Are there 24, 14, 9? Shit, sorry, I missed that. Or 10. Okay. We'll, you guys vote, and then I'll tell you the error I made. It's actually 15, so whoever said 14, you get it. But Yeah, they're coming in so fast and furious, we just had to update. But of course, we're familiar with the Michigan one as well. The bulk are in the States, but there's Germany, India, and England. What food contains the highest amount of copper? Okay, this may be contentious. I made a choice. Is it shrimp, dark chocolate, beef liver, or dried mango? The dark chocolate I would struggle with. It's beef liver, I believe, but I think they're all high in copper. But we'll talk about that in a minute. I should have brought them up. We have great resources to help you with copper-conscious eating. Okay, we're in the home stretch. Where were the original zinc clinical trials for Wilson disease conducted? Was it Yale in the 80s? Was it U of T? Was it University of Michigan? Or was it University of Edinburgh? So where was the original zinc clinical trials for Wilson disease conducted? I will give you a hint. It happened close to here, where we are now. Michigan. University of Michigan Medical Center in the 80s and the 90s. Okay, we're close. I know the bell went off. Who led the pioneering research for Wilson disease? Was it Franklin Enstein, John Walsh, George Brewer, or Samuel Wilson? So who was the lead investigator that was leading those trials? George Brewer, who I understand was a huge pioneer, and I think obviously you knew him, trained with him. Huge, huge influence. Okay, there you go. We have 3 winners. We have, oh, we got to do everybody. Okay, I got to grab your prizes. Ooh. Okay, well done, everybody. Good job, good job. I hope you learned a few things. We have prizes for the top 3 winners. As soon as we get them, what we got? Anne, who's Anne? Anne, congratulations. Okay, this is hot off the press, Copper Conscious Book Cookbook, first published, distributed at the Sacramento conference last year. This is the original edition. If you don't have a copy, buy one. You can buy on Amazon. It's a fantastic cookbook, and it's also got loads of fantastic information on copper-conscious eating. Anne, that is your copy. Sarah and V, please come up. Thank you, Anne. Congratulations. Sarah. Who's Sarah? Oh, copper-conscious. My husband's a huge foodie. He hates everything I cook. The sesame meatballs, he's like, can you make that again? He loves them. There are some fantastic recipes and some wonderful information. And V, thank you congrats. Thanks, guys. Have a great day. Hope you learned a thing or two. Okay.
That was a wonderful talk, wonderful icebreaker to get the meeting started. I can say, Alice, you lived up to your reputation, which is nice to hear. Exceeded it, actually. So now it's my pleasure to introduce Dr. Graham Brady, who's a hepatologist here at University of Michigan. He's got a real devotion to rare diseases. He works on laminopathies in his laboratory, which are diseases that are much more rare than Wilson disease. So he was a natural to get excited about working with Wilson disease, and has been an integral part of our research program for the last several years. And he's going to be giving an introduction on a Wilson's disease overview. So for those of you who haven't met Dr. Brady yet, here he is.
Thank you, Fred, and thank you to Tara and Rhonda and Alice and all the organizers. I was excited to be invited to take part in this. And as as Fred mentioned, being in the rare disease space, one of the really cool things which we don't get to do in other aspects of our work, but in the rare disease space, sometimes we do, is to have meetings like this where it brings not just medical professionals, but people who are actually impacted by the disease. So my mission today is to sort of give an overview. A lot of the information that I'm going to share will not be new to most, maybe all folks in this room, especially the trivia winners. I don't know if Anne would maybe come up and give this talk better than I could. But really just to set a baseline to make sure we're kind of like clear on the fundamentals, which will be important for some of the more exciting discussions that will happen later today. So my disclosures are listed here. These are all research funding from the various sources, and none of these are actually relevant to this presentation. So what is Wilson disease, right? I mean, I think most, maybe all, folks in this room have a sense of what Wilson disease is, but it is a rare genetic disorder of copper metabolism that is caused by variants in the ATP7B gene, which encodes a copper export protein. And what I haven't put in this slide, but what Alice sort of alluded to or explained, is that it is a not just a genetic disease, but an autosomal recessive genetic disease. So although being a carrier is fairly common, the disease manifestation is much more rare. So part of what is important about that, and we'll get into some of how we diagnose Wilson disease later, but part of what can be important about that is that the patient with Wilson disease may or may not have a family history, because they would have to inherit one copy from each parent, and there might not be a family history of Wilson disease on either side of the family. So the fundamental cause of Wilson disease is having two copies of a disease-causing variant in the ATP7B gene, and the fundamental cause of the symptoms of Wilson disease is that excess copper accumulation occurring due to the liver defect in copper excretion. The excess copper accumulation can cause damage to liver, brain, eyes, and kidneys primarily. Other organs can be impacted too, but these are the main ones. And as we already mentioned, it is a rare disorder, but it does occur worldwide and can cause anywhere from mild to, frankly, devastating symptoms, including liver failure. And as Rhonda mentioned, being a carrier is 1 in 90, but the actual disease prevalence is thought to be about 1 in 30,000. Okay, so this was the stage of making the PowerPoint when I decided to just have a little fun and test our AI overlords to see what GPT knew about Wilson disease. So I told our semi-proprietary GPT image builder, give me 2 slides about what is Wilson disease. So this is what it gave me. So the left half is pretty good, I thought. Genetic disorder of copper metabolism, impaired copper excretion, copper accumulates. Accurate. It identified the gene correctly. I thought it was a little bit disturbing that it didn't know where our eyes are. Located the brain okay, but then for some reason thought that the liver would be here between the 2 lungs. I'm not sure what happened there. So it was kind of usual for AI, mostly correct, but when you start diving into the details, it doesn't know where our eyes are. But as already mentioned, it was originally described by Dr. Wilson in the early 20th century, and I hadn't looked at his original report for quite a while until I was putting these slides together. I don't necessarily recommend going back to read it, because you not only you realize as you're looking through his reports how far we've come in terms of understanding what is Wilson disease and how can it be managed, but also in terms of the ethics of medical research and how clinical research is performed. I mean, there is identifying information and really not nice information, pictures about the children that they were following. But in terms of just putting all the ethical parts aside, which are many, it is a really comprehensive look at many cases of Wilson disease with that he and colleagues in England had started collecting from the 1880s. So that was the first description, but it was not actually confirmed for 36 more years from the same hospital, actually, that it was copper overload that was causing the neurologic symptoms that they were seeing. So it had been suspected sometime between 1912 and 1948 that it was copper overload that was causing it, but that was not really confirmed until late 1940s, and it only took a few years after that for the first patient to be treated with penicillamine, as the trivia taught us. Took a little while after that to figure out what was actually the gene responsible for this genetic disease. So it was an additional, how many years is that? 45 years until the ATP7B was identified as the causative gene leading to Wilson disease. And this was published by two separate groups in Nature Genetics in 1993, which was around the time, as Alice already mentioned, during the time when there already had been 2 treatments approved and zinc was being tested as a 3rd treatment. But the gene identification, although not necessary to initiate treatment, as we discussed, was really critical to understanding the fundamental physiology of the disease and provide a springboard for some of the treatments that are now currently in development that we're going to hear more about later. What is ATP7B? I'm not going to go through all the details of this lovely figure from our hepatology textbook, Sherlock's Diseases of the Liver. But essentially, this is ATP7B, the protein, is a copper export protein that is expressed mostly in liver cells, hepatocytes, and allows them to send the copper that is acquired from the GI tract to where it needs to go, either out to the bloodstream so that it can be used by other tissues. That's the ceruloplasmin pathway, sending copper out to other tissues so it can be transported and taken up in a regulated fashion. And then the same ATP7B protein sends copper out into the bile for excretion. So if you have 2 copies of disease-causing variants and limited or reduced or absent function of the ATP7B protein, you will have impaired copper excretion into the bile, which leads to copper overload, but also reduced ceruloplasmin in the blood, which is important from a diagnostic perspective, because that's one of the things that we can look for. We don't necessarily have great tests for how much copper is in your bile, but we do have good tests for how much ceruloplasmin is getting into your blood from the liver cells. Symptoms. What are the symptoms? So we talked a little bit about the pathophysiology. What are the symptoms? There are many. I don't have to tell people in this room necessarily, but the symptoms are many and can be from different organ systems and can be highly variable. Overall, this was a study, a joint study between China and the UK, where they looked at a few hundred patients and tried to sort out at what ages people are more likely to present with what constellations of symptoms, and you can appreciate that there's maybe more of a tendency to have liver-specific symptoms in younger folks. So you can see at the left side of the picture is kind of more maroon and pink, whatever that maroon color is, magenta maybe. Whereas in adults, which is mostly, I see adults in my liver clinic, they are more likely to have more prominent neurologic symptoms or just sort of all of the above. And it really, in terms of recognizing Wilson disease, it requires a very high index of suspicion, because there may be different presentations and multiple symptoms, and it's kind of looking at the whole picture and tying it all together. A little bit more fun with GPT. How do we diagnose Wilson disease? So this is partly correct. Blood tests, I mentioned blood tests. Blood tests can be helpful. One of the things is, are we suspecting that this person has liver disease? We might determine that based on blood tests, and then further blood testing can give us a sense of whether Wilson disease could be the cause or not. Eye exam, again, the GPT doesn't know where the eye is. It seems to think that we're putting a needle near the liver, and that's part of the eye exam. But to give it credit, eye exam can be part of the diagnostic pathway for Wilson disease because eyes are one of the places where copper can deposit, and obviously you cannot see copper in the liver or in the brain just by examining the outside of a person, but our skilled ophthalmologists can recognize copper deposits in the eye by doing a careful and special kind of eye exam. Liver biopsy, although labeled incorrectly there, is often part of the diagnostic evaluation because although we can't see copper in the liver on a physical exam or an ultrasound or an MRI, our pathology colleagues can see copper in the liver on a liver biopsy specimen. So this is how we actually diagnose Wilson disease. Am I going to go through these algorithms? No, I am not. But just to give you a sense, this is taken from our American Association for the Study of Liver Disease guidelines. It's very complicated, and it depends on whether the person has primarily neurologic symptoms or primarily liver symptoms. We have a very complicated algorithm to go through, but the fundamental the fundamental principle that I think is most important is it is complicated, and we have to have a very high index of suspicion. So because if you're not thinking about and looking for Wilson disease, you may not find it. Treatment, we're going to hear a lot more about the exciting and new forms of treatment later. GPT does not know about zinc. It only knows about the chelators and the low-copper diet. But in reality, treatment does include chelation. Treatment does include zinc. And kind of the way I think about it, and Alice mentioned zinc as a maintenance therapy, chelators help get the copper out that's already there, and the zinc helps inhibit or block excess copper absorption from the GI tract. For patients who present with liver failure or advanced liver disease, or if the treatments are insufficiently effective, liver transplant is often an option. And we're going to hear a lot more later about gene-targeted therapy, which is kind of the next cutting edge where treatments for Wilson disease we hope are headed. And that is, 30-some years after the gene was identified in the 90s. So to sum up, Wilson disease, as you all know, it's a rare genetic disease with variable clinical presentation, and in order to ensure timely diagnosis or to hope to achieve timely diagnosis, as is true for many rare diseases, high index of suspicion is really required. We've advanced a lot in the last 100 and so years in terms of understanding how Wilson disease happens and how we may be able to treat it. And you're going to hear more later about some of the novel treatments that are in development and in clinical trials now. So to finish, I'd like to thank the folks here at the Wilson Disease Center of Excellence, and also Tara, and Nicole, Rhonda, Alice at the Wilson Disease Association for allowing me to take part in today's event. And I always acknowledge my funding sources, although they have zero to do with today's talk. I'd be happy to take any questions later. Thank you.
So now it's my pleasure to introduce Dr. Alex Teixeira, who is a clinical psychologist who we work closely with in our transplant center, and he's going to talk about coping strategies, particularly in Wilson disease, but he has really extensive experience counseling people on coping with very stressful medical situations. So when the opportunity came up to ask someone to speak, I couldn't think of anyone we'd rather have than Alex to talk about coping with a stressful situation of being ill. So thank you so much, Alex, for participating.
All right. Thank you, everybody, for having me here today. I'm just going to be going over, as the slide says here, just how we want to navigate some of the mental health challenges that, of course, a lot of people face in dealing with Wilson's disease. Dr. Brady mentioned a couple of different things here as to the multidisciplinary approaches formed in treatment here for that, and I believe I kind of represent one of those members of that. So one of the multidisciplinary areas here to be kind of going into. And so I wanted to kind of skip over some of the overview there. Obviously, we kind of are well acquainted now with the disease and everything from the previous two components here of our talk. And so in going over some of these different things, I wanted to mainly point out here that when thinking about treatment, a lot of times, obviously, it is liver-focused and physiological focus. And that's not really much of a critique, but more so, rightfully so. That is kind of where the main focus is in trying to treat some of these different things. And still, it just goes to show that a lot of these psychiatric symptoms, they're very prevalent, obviously, within Wilson's disease. And the psychiatric issues sometimes are often cited as one of the biggest treatment challenges that people face. And so despite the high prevalence, there's actually, as I was kind of going through some of the research for this, surprisingly little as far as treatment guidelines for managing the psychiatric symptoms that are specific to what those with Wilson's disease experience. And so, yes, we've already met Samuel Alexander Wilson throughout here and his seminal paper there in 1912, 1911, give or take there for that. He described in the 12 cases that he was following, and it's very interesting here that he even described 8 of those 12 cases he was examining at that time experienced so-called psychic or psychical, I think he used in the paper there, symptoms. And so he was even able to witness described hallucinations and delusions, slowed thought processes, behavioral disorders, mood disorders. It just really kind of shows here, since he saw it in 2/3 of the people that he was even going through to begin with here, the link between mental health symptoms and even neurological symptoms and Wilson's disease is nothing new. It was even identified by the founder here of this, obviously, even a century ago. And all this to say as well, in that analysis of a multi-center international Wilson's disease registry, it found that approximately 37% of patients had a lifetime history of major depressive disorder, and 6% had an active episode of major depression at the time. And other studies have shown, obviously, prevalence varies widely here. Other studies have shown the prevalence of depression can be even higher, at 60% of the patient population experiencing depression at some point. And so here, oftentimes the mood and cognitive symptoms can sometimes be the first indications, as we've kind of learned about. Sometimes it can be a mixed presentation there between hepatic symptoms and neurological symptoms, or even mental health symptoms here for that. I thought this was interesting as to where about 20% of all patients actually reported seeing a psychiatrist first before seeing any other physicians or other hepatic providers there for that. So the first place where they got in the door was with a psychiatrist or a psychologist there. So that's 1 in 5 there for that. And so now just wanting to discuss the origins or the cause of the psychological or cognitive issues, and this is a little bit over my head here for some of these things, but still just wanting to kind of go into this a little bit here at the surface level. There are obviously many thoughts as to the mechanisms behind some of the symptoms that we've noted here today. For instance, as well that contribute to depression, that there's a point in the impact of the disease on daily life, the disruption caused in dealing with symptoms and dealing with medical treatments and related responsibilities. That obviously plays a role in how people adjust or are impacted here in their treatments. Managing chronic illness, it can obviously be like a full-time job. And that can obviously also interfere with your home and work-life balance as well too, trying to balance all these different things. And although that can't really be the only explanation due to what we just mentioned before as to where a number of individuals oftentimes report the experience of these psychiatric or cognitive issues before they have even yet to receive a diagnosis. So how do you kind of explain some of those things? That's where the biological bases maybe take over here for some of this. And so in going over the different biological bases here, this includes copper toxicity and buildup as even minor disturbances in our copper metabolism. It can lead to either excess or deficiency in that copper. It can obviously affect various brain functions there. That includes damage to the basal ganglia, which functions as one of the main areas of the brain. It manages movement along with it being our primary reward structure within our brain, and cognitive functioning and obviously emotional behavior and processing there. This can also help thread the needle here and explain how Wilson's disease, there's a higher prevalence that we find for depression than most other chronic health conditions. As we see there, rheumatoid arthritis listed there specifically, but we see a higher prevalence in depression among those with Wilson's disease than other types of chronic health diseases as well too. And in fact, the levels are so high, the rates are so high of depression here, they're actually what we see more similar to those with other neurodegenerative diseases that also involve the basal ganglia, like Parkinson's or Huntington's disease. Our prevalence rates of depression are actually more in line with those diseases as opposed to other more chronic health diseases. And so now just going into the different forms of treatment for the psychiatric concerns. Obviously there is most empirical evidence for medications, for medication management here of mental health symptoms. So in going through all of this, I should say I'm not a psychiatrist. The differentiation between psychologist and psychiatrist. Psychiatrist is able to prescribe. I do more of the therapy, the counseling part of things. So I'm not able to elaborate too much heavily on the different medication options there, but wanted to at least provide this table that I came across there as to what are some of the preferred treatment options here for those that are kind of going through these mood disturbances. Mainly depression listed here for this. So you see the big three right there, those SSRIs. Those are kind of also the general ones that we use for a lot of the population that deal with depression or anxiety at some point in time. Citalopram, escitalopram, sertraline, maybe better known by their usual brand names there, Celexa, Zoloft, and Lexapro. These are medications that are frequently used, like I mentioned, across the spectrum of depression, so not just specific to the health components here that we're talking about. And some more as well, some similar ones here as you can see before as well too, and in going through some of these, the behavioral disturbances can also be tackled by these medications, not so much for the cognitive deficits, but from different neuropsychological trainings and other brain games, different things like that. You might not be able to replace what you lost, but at certain times you can probably stop or slow some of the speed of those deficiencies there. And so next, as it relates to therapy, there's not really one modality that's specifically tailored to Wilson's disease, but the gold standard of all therapy that we come across here is cognitive behavioral therapy. It's used to help modify maladaptive thought patterns or behaviors to better improve our emotional regulation skills and overall functioning. And it can be best to work with a clinician, I think, that has a health psychology background. There are plenty of great counselors, but I think those that have a background in understanding disease, understanding chronic illness, I think that that's kind of a specialty that you want to find with the therapist that you're working with. And the counseling that I think is the best approach here for that, and any main tenet that you might find in any type of health psychology approach, are the core ones here: mindfulness, acceptance, and resilience. So also we have perceived social support here. Social support can be a very important factor and actually sometimes trump all the other three of those. So speaks to the importance of the social supports, the caregivers that we have in the audience here today, obviously. But just to touch on the other three here a little bit, just to go over mindfulness, it involves the conscious, non-judgmental focus of one's attention on various internal and external experiences that are occurring in the present moment. So with this emphasis of intense focus on the present moment of one's experience, it can help promote self-regulation, can help improve our own self-control abilities as well too. As oftentimes we get too far caught up looking into the future or worrying about what lies ahead, and instead sometimes looking as well in the past and feeling depressed about what we might have lost. So this approach kind of helps us keep grounded in the present, not looking too far forward in the future and not looking too far back in the rearview mirror there. Resilience, it's an individual's ability to adapt and rebound psychologically in the face of adversity, trauma, or extreme stressors. And in going through some of these different things here, the resilience, it not only helps individuals adjust their own mental state and overcome difficulties, but it also enables one to better reshape themselves and actively cope with the illness rather than feeling entirely defeated by it. The last one to cover here as well is acceptance. I think acceptance gets a bad rap in general, just the word itself. That's something I tell my patients all the time, I feel like, because a lot of times if we think that we accept something, that we condone it, and that's not often the case. You know, it's not often the case that we are condoning what's going on here or what we're dealing with. But in trying to describe this, I often think about a quote that I heard from Michael J. Fox, one of the famous actor, obviously, and also infamously known as being diagnosed with Parkinson's disease. He says, and I quote, "Acceptance does not mean resignation. It means understanding that something is what it is and there's a way through it," end quote. And so by doing this and taking this approach, one can maintain a more balanced awareness of the disease and regain a sense of personal control or ownership by integrating the experience that you're going through into your own lifestyle. This can often center around making compromises. That's a big component here. And so trying to find a way to glean some sense of enjoyment, some sense of purpose, or optimism in the situation despite one's own functional limitations. And this quality here of the disease acceptance part of this is often noted as one of the most crucial factors in one's adjustment to their health issues and in mitigating any potential related depression or anxiety from what you're dealing with. So some last takeaways here. So for some of this, just to wrap up, there's obviously so much to cover here, and I didn't even get to touch on, I think, some more of the severe aspects of mental health in those that deal with Wilson's disease. But main takeaways, yeah, if you feel something, say something. I think wanting to just try to destigmatize any aspects of mental health here for this, just make people, either raise awareness, or if this is something that you're going through, make you feel like you're not alone with those prevalence statistics at the top. More likely than not, this is going to be, someone in this room is going to be experiencing or is already experiencing some of these different things. So I think overall, just wanting to make sure that you want to try to use this talk to think about how you're going to cope through difficult times in dealing with chronic disease, take that personal inventory there, but think about the helpful or unhelpful things that you're talking about, or that you use, that self-talk that you use when your stress is high, or if you're not feeling well, or also think also to take inventory of the coping skills that you're using to try to tolerate or deal with these situations. If you feel like you're coming up short in any one of these different areas here, obviously reach out for help. There's a variety of treatment options as we covered, medication management, therapy, a couple of good therapy resources that I offer all of my patients as well too. SAMHSA.org, that is SAMHSA.org, stands for the Substance Abuse and Mental Health Services Administration, and also psychologytoday.com are two resources I give to all of my patients there if you're looking for getting started in therapy or just kind of looking over your options there. That's all I have, so thank you guys so much.
Thanks for that great talk, Alex. I think we all can benefit from reminders about that and how to cope with stress and whether it relates to disease or not. So that was really wonderful. One of the things I wanted to remind people is please write down your questions. Put the speaker you're asking the question to, and volunteers will be circulating to pick up the questions so we can have a question and answer session after the final talk of this session. So I'm really excited to introduce you to Kim Lee, who many of you know through our patient portal. If you're a patient at our center, she's the Wilson disease nurse specialist and has been working on this for many, many years now. I won't say how many, but a long time. And the exciting thing about Kim is she's really working in the background, doing everything that we can do and helping to coordinate all patient care. And she's going to talk a little bit about the nurse's role in Wilson's disease management and really we couldn't do anything we do without her help or help of a nurse like her. So we really appreciate you talking today.
Good morning, everyone. I'm so excited that you're here today, and I'm really excited to be a part of this. And thank you to the Wilson's Disease Association for putting this together. And thank you to Dr. Scurry for inviting me. So before I get into this discussion, I just want you to know I may sound like a broken record, but it's okay because there are overlapping themes here. Let me just get my first slide. Okay. So this is what I can show you of how best to optimize the nurse and patient relationship. As nurses, we tend to have a baseline knowledge of the patient population that we serve in not only the hospital but the community as well. This includes assessment and education. This is a big part of our everyday care. It is ongoing, including but not limited to assessment of symptoms, which we have heard from earlier, review of the current medications that you are taking, and also adherence to the diet, which includes low copper, and education about your disease process. And so the next slide that I want to show you, this is a quote from Susan Bradley. She's a nurse, and she is also in literature for nursing education. This is one of my favorite quotes. And so nursing is a journey. Every day we learn a little bit more, we grow, and we change. Being a nurse in today's world especially, I'm learning constantly from patients just like you every day. When I first came to the clinic in 2019, I was aware of what Wilson's disease was. I just did not know how it greatly affects everyday life. Okay. So having the my favorite word, my favorite phrase I want to say right now is let's talk about it. So this means having an open dialogue, whether by phone call or a portal message in a timely fashion that I will get back to you. If something's going on, if you're having symptoms, let's talk about it. The best way to get information to the providers is just to review your symptoms. Is there anything new going on? Have you had an illness recently? So that's a good starting point. Also, if you're having issues with accessing medication, I'm a good person to start with. We do have a pharmacy tech that is available. Her name is Brittany. You may have also encountered her many times. So this is just a great way for me to start that conversation. And so talking about what may be going on at the present time is essential to assess a full clinical picture. I may ask you more in-depth questions. And if the labs are concerning, we want to know if you have a recent illness, like I said before. How are you following your medication schedule? Life happens. We all get that. You may be traveling, so you may have gotten off your regimen. That's okay. We just need to know what's been going on. And then also for symptoms, it can be kind of a gray area because as you may have seen, so many different symptoms present in different ways. If you're new, if you haven't been established with our clinic, or if you know of other patients who are going through something similar, be sure that you insist that they get either a second opinion or just more follow-up and what's really going on there. Also, family members have been reporting observations that they may perceive as normal, or that you may perceive as normal, but they may just notice some subtle changes such as mood, behavior, some tremor, changes in swallowing, and that gets to the progressive part of the disease. So communicating these changes in your health, no matter how small, it is important. This can often slow the progression of the disease by pinpointing what is going on. Okay, so you see this cartoon here. This gentleman's brought in his urine collection, and he's stuck in traffic, and then, so hey, my sample's ready. So the 24-hour urine, so let's talk about it. Why collect the 24-hour urines? It's essential for monitoring your copper overload by measuring the urinary copper excretion. The urinary copper indicates disease control or worsening, medication adherence, as well as are the therapies effective? Are the dose adjustments needed? I'm not the one to change your doses. That would be up to Dr. Scurry. And then most importantly, do not change your dose on your own without guidance from our clinic or your local provider. But do complete these at regular intervals. Typically, they're every 6 months, unless we have dosage changes or treatment change. So then some questions we may ask. If we haven't heard from you in a while, I may reach out to you and ask, when was your last urine collection? Sometimes we have patients who go locally, and that's totally fine. We do understand that insurance can be a barrier, and we just don't want you to go without getting tested. So we may want to increase your dose. We may want to decrease your dose. But again, the urine collections, we may want to do this in 3 months just to know how the treatment is being effective. Let's see. I'm always willing to review the process of the 24-hour urine. Even if you've been doing this many, many times and you just need a refresher, that's fine. I'm here and I'm happy to help with that. And so I do my best to try to put in reminders to when we have to send out the urine kits. But also, please keep in mind that this is part of your job to just know, like, okay, my urine's coming up in another month or two, maybe I should just call the clinic. Again, that's open dialogue and no judgment. So the next slide. This was talked about a little bit more in depth. I'm not going to get too scientific with it, but just know that there are therapies out there. And one of the biggest concerns that we'll talk about also is financial difficulty. So we understand that not all these medications can be accessible, but we just want to make sure that you just don't stop treatment. So I'll get into that a little bit more. So 24-hour urine testing is essential because we want to make sure if you're on zinc, we want to make sure that that's effective. And also the trientine, when it was mentioned about kidneys, the urine protein can affect the kidneys as well. So we just want to make sure that we're not doing anything with that. Blood draws. So we have many different labs that we're monitoring pretty closely. We have usually once a year, or it could be every 6 months. It just depends on your individual situation. So please keep in mind, again, if you find yourself in a situation where expense is prohibiting you from getting your labs or urine, let's talk about it. Dr. Ascari can work with you, and at minimum, there are some labs that will be great, just so we can keep an eye on that picture. Okay, so I'm going to skip to this one. So we just want to, again, prevent copper toxicity or prevent deficiency. So balance is key. And then again, medication appropriate intervals, prevention of copper deficiency. We want to make sure we're following not only the labs, but the 24-hour urine that gives the whole picture. So we just want to make sure we're on track with that. Okay, so prevention of copper-related complications. Go over that real quick. So this is a long-term treatment. The goal is prevention of complications such as copper overload, neurological damage, cirrhosis, and again, like I said, kidney dysfunction from trientine. But then, you know, if your liver is impacted, it could also affect your kidneys. So my role as a nurse, I'm going to continue to encourage you to stay with your medication adherence. I'm going to continue to provide education about possible risk of non-adherence. And also a reminder with following the low copper diet and drinking water that is distilled or reverse osmosis water. And then also, we'll also have a conversation if a dietitian referral is appropriate. We do have a hepatology nutritionist if that is appropriate. Okay. So one quick thing that I'm going to mention, we do have Brittany, who is our pharmacy technician. She is just monumental for getting through the financial barriers for access of medications. So if that's an issue, let's talk about it. So just let me know if you have a job change, a loss of insurance, anything that might be that barrier. Brittany is wonderful in getting you access to the patient assistance programs and just letting you know what assistance is available. So I just wanted to show you, for those of you who are getting your bone scans, the DEXA scan, this is what that looks like. Not scary. It takes about 15 minutes, and it's recommended about every 2 to 3 years. So Wilson's disease, we just want to make sure that we're looking for early signs of osteoporosis to keep your bones safe. So it looks at 2 major points, and that's the lumbar spine, and then the femoral neck. Hip fractures are very common, and then the lumbar spine is generally where the fractures begin. Okay, and so again, this is me at the broken record. So the liver monitoring also includes liver imaging, as well as doing all the testing with lab draws and with the urine testing. So if you're fairly new, we may do a fiber scan just to see what the overall health of the liver is. And if you have progressed to cirrhosis, we will ask that you have liver ultrasounds every 6 months. And that is just, we want to make sure that there are no signs of liver masses or further disease. So, in conclusion, the nurse's role in optimization of comprehensive care, coordination of urine, blood testing, medication adjustments, and patient education, ongoing communication. So this is an open door. Anytime you have any concerns, any symptoms, if you have questions about your plan or treatment, we just want you to feel heard and supported. And this also supports optimized outcomes. It results in better disease management and prevention of complications and enhanced quality of life. And I thank you.
Thanks, Kim, for that wonderful talk. Thanks, Kim, for that wonderful talk. And with that, we move on to the question and answer session. And our folks will be circulating to pick up your questions. And then we'll be asking the speakers. So if you can get your questions out, the volunteers will be circulating to pick them up. We've got a few here already, which is great. And then if the speakers want to